22A. And we're still talking about the anemias. And we're having a lot of fun talking about the anemias. We talked about thalassemias, megaloblastic anemias. We talked about sickle cell anemia. We talked about clinical features of sickle cell disease. And now we're moving on. Let's speed it up. What are we going to talk about next? Well, guess what? We're going to say a few more things about megaloblastic anemia. We talked about vitamin B12 deficiency leading to folate deficiency. Remember that intrinsic factor is very important in the gastric mucosa to absorb vitamin B12, but with pernicious anemia, that's not going to work out. So remember that vitamin B12 is absorbed in the terminal ileum. Where is it absorbed? In the terminal ileum. And defects at any of these sites can produce a megaloblastic anemia. So there you have it. Anything else? What is B12, by the way? What's another name for that? Cobalamin. Cobalamin deficiency can lead to what? Pernicious anemia. Yes, a lack of folate causes anemia in B12 deficiency, and vice versa, it seems. Okay, we're just going to have some quick definitions here, and you're going to give me some examples. What is leukopenia? Number of circulating white blood cells is decreased. And where would you see this? In advanced HIV infection. Or where else? After glucocorticoids or cytotoxic drug treatments, and in autoimmune disorders, leukopenia. So we're talking about leukopenia or neutropenia or agranulocytosis. This is an inadequate production or an increased destruction. So 500 to 1,000 millimeters cubed is the danger zone. Remember that, 500 to 1,000. So concerning inadequate production, if you had stem cell suppression, what would this result in? For example, aplastic anemias. And then there may be a result from drugs, for example, chemotherapy, many antibiotics, aminopyrine, thiouracil, and phenylbutazone. And remember that DNA suppression is due to the megaloblastic and myelodysplastic states. Kostman syndrome, which is genetic congenital, aka severe congenital neutropenia, which affects the myelopoiesis. That's Kostman syndrome. Marrow usually shows granulocytic hypoplasia, just as in red blood cells, and platelet decreased production. What are plats? Platelets. So we just talked about inadequate production. How about increased destruction? Where would you see increased destruction? This might be immune mediated by itself, or idiopathic, or such as is seen in lupus after sensitization by many drugs. So in this case, with the increased destruction, you would see splenic sequestering and hypersplenism. There would be an increased peripheral demand, as in overwhelming infections, for example, fungal. And the marrow would usually show a granulocytic hyperplasia, just as in the red blood cells, and the platelets increase destructions. Remember, there'd be granulocytic hyperplasia with this increased destruction. Okay, it's time to move on and talk about the leukemias, another big subject, leukemias. Anyway, let's talk about them and just say, as a summary, it is about the malignant proliferation of white blood cells. We've talked about them in detail before, but let's just summarize here. We know that in the case of neutrophilic precursors, what happens? Tell me about the primary process. The primary process is marrow and peripheral blood, but can involve any organ or tissue which receives blood. In the case of lymphocytes, remember that there is an intimate concurrence with malignant lymphomas. So with the neutrophils, precursors involves the marrow and peripheral blood and any organ which receives the blood. But the lymphocytes, you also have to consider lymphomas.